So the learning objectives of today's webinar we want to achieve, as usual, we have a multinational audience. So what we want to achieve is a learning objective of conveying knowledge and skill from APPS panelists like all of you to the doctors in, I think, 8 or 9 countries. Abdul Bhai, can you update me how many people have been able to join or will be joining today?
On an average, we get about 27 different countries. I think today we are across 20 at least.
So 20 countries, and it's a multinational participation. So the topic, whatever we talk about today, we're not talking about specifically a country. We're talking about the principles of management, but we can give a reference where it can be applicable, where the most audience is from.
We are going live now.
Yeah, that's fine. Okay, let's carry on talking about it. So Dr. Shaheena Anjum, your presentation, and then we have Dr. Sundus Yahya's presentation. Then we'll follow with Dr. Syed Ali Raza. And then after that, we'll have a quick round of comments from Dr. Taimur Mirza and Dr. Shahid Sharif. After that, we will open the house for questions. Before we start formally with the presentations, I will be inviting you for a quick round of introductions. And then we'll take on one by one after. I hope that's very clear and there's no doubt about it.
Absolutely. I think what we need to also announce is we are going live on social media as well, because we are oversubscribed 3 times than our capacity today.
That's fine. That's a good point. That's a very good point.
So people can actually ask questions on Facebook, as well as on the chat, which obviously the panelists will keep an eye over here.
So we have Facebook, somebody monitoring Facebook questions.
Absolutely. And then people can access Facebook through our website.
Correct. Right. Absolutely good. So we have still 7 minutes to go, and I will do the countdown before we all take up this matter. At the same time, one thing we want to do is we want to mention towards the end of the webinar, Dr. Sundus Yahya's contribution towards the palliative care project of APPS UK, and that is where we close off the whole thing. We have Dr. Sundus Yahya joining us shortly. Yes, I think we would be able to accept her joining in now if she wants to come in. So
we have quite a bigger issue at the moment, which is in the media in terms of BME deaths.
Oh yeah.
So it's actually affecting a lot of, especially the Asian population. Up to last figures, 29 out of 31 deaths in doctors were in
that's a very, very significant statistics. 29 deaths out of 31. It's very significant. I've not seen this kind of predilection before. So I think this topic could be discussed at some reasonable platform. But today we are going to focus on atypical presentations of COVID and also the end of life care. And
Assalamu alaikum, can you hear me?
Dr. Sundus, yes, we are live, but we are just waiting for the broadcasting. Alaikum salam. And we're just kind of warming up to the topic that we're going to leave a learning objective of the message to take home would be, what are the atypical presentations of COVID-19 and what does it involve in the end of life care? So with your help, we're going to sail through these topics and leave a wealth of information, skill, and knowledge. APPS is doing that for quite some time, and we're going to really pronounce on it again. Thank you very much for joining. And we've got 5 minutes to go live. We are live, but we're going to go 5 minutes to start the webinar. People are listening to us.
Okay.
People who've already joined us, let me tell them that we haven't started formally yet. And if you're listening to us, we are also live on Facebook. If you want to send the link, if you just have to search for Association of Pakistani Physicians and Surgeons on Facebook, you'll find our page. And that page link you can send to your friends who want to join, or you can share on your own timelines. I think people should benefit from what we're going to talk next. Luckily, I have got the presenters with me who have got first-hand knowledge of managing this very very complicated problem of atypical presentations. They've got hands-on experience of sharing today. So I would welcome if you want to share this link of APPS UK's Facebook page to any length you want. Dr. Shakeel Puri is, welcome Dr. Shakeel Puri.
Ji, Assalamualaikum. Assalamualaikum to everybody.
Yeah. So we have 3 minutes to go live. And
yes, I'm absolutely ready from my side. I wish you all best for whatever you're planning to do.
Okay.
And I let Dr. Suhail Chughtai take the lead. Dr. Irfan Rashid bhai and Dr. Abdul Hafeez bhai are ready with their questions and so forth in the end. And yes, I'll be in a supportive role today, inshallah.
Yeah. So
nice to see you, Ali.
So we are going live in 2.5 minutes from now.
Yes.
Okay. In fact, 2 minutes. So I'll do a quick countdown and we should be live in about, I think my clock says actually 1 minute, the updated clock. So guys,
still 2 minutes, I think.
Yeah. Okay. So let's leave a strong message from APPS. You know, we have been doing advancing health, changing lives, and we'll keep doing it. Welcome, Dr. Shahid Sharif. Just trying to connect to the audience, audio. So Dr. Shahid Sharif, we are live at the moment, although we haven't formally started. So people can hear us and people can see us now.
All right. Okay.
So we welcome you, and hopefully in 1 minute time, we are just going to say a formal welcome to the audience who is joining from 20 countries, 20 plus countries, in fact. And again, 20 plus countries, yeah?
Yeah, I think very important point. Absolutely 20 plus at the moment. I think what we should also do, as well as we will recommend our attendees for the masses to benefit, that if they go on Apps UK website, which is very easy, appsuk.org, and you will find Apps UK link there. Mm-hmm. And obviously we will advise, obviously, and recommend people to share this live webinar so it can actually reach on your timelines and, you know, much bigger audience. So we have a whole panel of experts here who will be answering the questions. People can actually write the question on Apps UK Facebook page. We'll keep an eye on any interesting questions over there, and that they will be put forward to the panel. As well as people who are joining us on the Zoom can send question in the chat box, as well as Q&A. So these questions, obviously, you know, selected questions, we normally get a very big number of questions. So those selected questions we can actually put to the panel as well. I think we are ready
so
to
I
go
think
live.
The countdown will be 10, 5.
Going live now.
Thank you. Well, Assalamu alaikum, good evening, and in some places, good morning, because you're joining at APPS UK webinar, the weekly Sunday webinar from 20 plus countries today. So I really appreciate you taking time out today, joining from various countries and giving us a hand in the propagation of knowledge about COVID-19, which is the current challenge to mankind. COVID-19 has assaulted us, and we are trying to get information exchange portal through APPS UK to all of you. So I welcome you all. Thank you for taking time to join us. I also welcome my panelists, and I will be going round with a brief round of introductions. But before that, let me tell what APPS UK is about. It's about advancing health, changing lives. APPS UK is the largest Pakistani Doctors Association in UK and Europe. More than 10 years being in service. And then I think now we've reached a point where we are almost global by sharing knowledge and exchange through this modern medium of webinar. So welcome my panelists. I really welcome you today. I know it's not easy to be fasting at the same time presenting, but I really appreciate you taking time. Can we go through a quick round of introductions before we start formally? Can I start with the president of the organization, Dr. Shakeel Puri? please.
Ji, Assalamu alaikum. I'm very thankful to the very able and devoted team of APPS UK to give their valuable time in this teaching and training session once again. My name is Shakeel Puri, and I'm very proud to be part of this fabulous team who's been giving services to the medical professionals all around the world, particularly in Pakistan, for well over 16 years. And especially in these difficult times when COVID is affecting many lives, we are unitedly working very hard on most weekends, in fact, every Sunday, to do these sessions, which are watched all over the world. And currently, I think well over 20 audience of well over 20 countries are watching us. So thank you very much once again, and I hope this will be useful and used as a sadqa jariyah for all of us in the future. Thank you.
Thank you, Dr. Shakeel Puri. The CEO of the organization who is behind the APPS logo today, and we invite Dr. Abdul Hafeez to kindly share a thought about the organization's work so far before we go for introductions. Dr. Abdul Hafeez.
Ji, thank you very much. As Mr. President has kindly mentioned APPS UK, briefly, what I would, generally mention is obviously this particular webinar is a very high academic value. We would like all participants to obviously introduce this webinar to other people, their colleagues, and obviously they can benefit from these as well. We would also like in future, start giving out the certificates of attendance as well, which can be used as CPD points to APPS. So I would encourage all of you to become APPS UK member, please.
Thank you very much, Dr. Abdul Hafeez. We have Dr. Shaheena Anjum, the chairperson of APPS UK, join us. Dr. Shaheena Anjum, please introduce yourself.
Thank you very much. Assalamu alaikum. I'm Chair APPS UK, and professionally I'm consultant pediatrician in the UK. It's an honor to be part of this panel and contribute as much as I can. You have already heard about APPS UK ethos, and today's seminar is more about COVID. So I will be presenting some information which most of you probably know, but when we get to it, we'll discuss that. So thank you very much for joining us today. And we hope that you then relay this information to who could not join us on this webinar today. Thank you very much.
As Dr. Shaheena Anjum said, that please use the Association of Pakistani Physicians and Surgeons Facebook page, and there is a link, and then you can spread that link further to your friends. Can I invite the Vice Chair of APPS UK, Dr. Shahid Sharif, who's kindly joined us today, to introduce and say a few words. Dr. Shahid Sharif.
Thank you, Dr. Suhail. It's my pleasure to be part of the APPS UK, and I'm pleased that through this webinar we are reaching globally and providing information, and also we had a few webinars on training as well. I am clinical oncologist by profession, and since I have been involved in APPS, it's always a pleasure to work to as Dr. Suhail said, for advancing health, improving lives, the ethos of APPS. Many thanks.
Thank you. We have Dr. Taimur Mirza's presence, a very able gentleman in the world of anesthesia. Dr. Taimur Mirza has been the ex-president of APPS UK. Thank you, Dr. Taimur Mirza. Please introduce your work to us.
Thank you very much, Suhail. Very kind of you to invite me on this as a panelist. My name is, as you mentioned, Taimur Mirza. I'm consultant in anesthesia and intensive care medicine. I work here in one of the hospitals in Greater Manchester. We have been treating patients of COVID-19 on intensive care units. Some of them have been very lucky to survive, but few of them unfortunately could not make it. So I can contribute whatever little I can do in this.
Thank you. We have the presence of Dr. Sundus Yahya here, very, very relevant to what we're going to talk about today. Dr. Sundus Yahya, please introduce your work to us.
Assalamu alaikum, Ji. Thank you very much for inviting me as a panelist. I'm a consultant oncologist. I work in Birmingham, but being at the heart of sort of Midlands, I was quite heavily involved in how we devise the pathways and introduction of how to manage the COVID patients, but at the same time, how to keep on going with the cancer pathways as well. I would also take this opportunity to use this platform to talk a little bit more about the palliative care, which a lot of us really struggle with, and has particularly been pertinent and relevant with this COVID-19 pandemic. So hopefully we can take away some messages home and try and contribute effectively to the management of the patients. What we will also try and do is not only give some guidelines to the attendees here, but also to signpost them. So they can always just come back to the Apps UK website, and there should be some helpful links for them for future management of the COVID-19 patients as well.
That's wonderful, Dr. Sundus Yahya. I think APPS UK will be supporting you in this initiative of palliative care guidelines for Pakistan, and you are already at the level of expertise where you can really teach and benefit so many doctors. Thank you again.
Thank you.
We have another panelist, Dr. Yahya, who has just taken a short break as he's from Bahrain and the time scale is different there. He would be joining back again. I want to invite Dr. Irfan Rashid, who is the person coordinating behind the scenes, and if he looks smiling and relaxed today, I would give credit to Dr. Irfan Rashid, who's also a very able gentleman. Dr. Irfan Rashid, please tell us about yourself before we
start. Thank you very much, Dr. Chughtai. Yes, I am a family physician working in West Yorkshire, United Kingdom, and also got a special interest in pediatrics. Before becoming a family physician, I was working in pediatrics for about 15 years. I'm also executive council member of Apps UK and also social secretary or Apps UK as well. And many of the attendees probably know me through WhatsApp. I think I've been coordinating all these webinars for the last 6 to 8 weeks and communicating with them through WhatsApp. And I must apologize because I've got at least over 1,000 of attendees who text me, and sometimes I cannot reply their queries, and it may be because I'm bombarded with all those text messages, so I do apologize on that behalf.
But you're still doing a great job, Dr. Irfan Rashid. We owe you a lot. Dr. Yahya, Dr. Syed Ali Raza is back now. Dr. Syed Ali Raza is a guest panelist today. And before we start the formal presentations, Dr. Syed Ali Raza, please tell us about yourself today.
Okay, I'm Dr. Syed Ali Raza. I'm a consultant oncologist right now working in Bahrain and going to join NHS very soon. Along with that, I'm a brand ambassador for the APPS UK for the last 1 year, and I have been involved in many educational activities and projects in Pakistan.
Thank you very much. So before we start, my name is Suhail Chughtai. I'm an orthopedic surgeon based in London. I'm also the director of digital health and telemedicine for APPS UK and have got a professor's title in telehealth and the director of the information and telemedicine for University of Health Sciences. So shall we start, if everybody is agreeable? And I think we will take Dr. Shaheena Anjum. You've got a presentation to share today. Do you want to start your presentation now?
Yeah, I'm going to start with my presentation now. Coronavirus is...
You have to start the share button. Yeah.
I'm sharing it, just a brief introduction.
Okay.
There's a lot of information going on about coronavirus on internet. Some is from authentic sources and some is not very edited type of information. So it's very difficult to follow what is the right way forward and what to believe and what not. I'll start my presentation with brief introduction of coronavirus because there is this myth. People think it has only started in 2019, There have been some notifications on disinfectant bottles, and they are linked to conspiracy theories that people knew about it. Coronavirus, it was first discovered in 1930 in chicks. These young chicks were having acute respiratory symptoms and dying, and a huge number died suddenly because of these symptoms. Then they were I discovered in 1960s in UK and US at the same time through different kind of tests.
Sorry, Dr. Shaheena, are you sharing your slides at the same time?
Yes, I am. Is it not coming?
Try again. I
No,
think
no, no. Let me. Sorry. Let me try.
Yeah.
And
if you click the screen,
yeah.
share button and then desktop share.
Okay, share. Is it coming?
It should come up. Yeah, we got you. We got you.
Okay, now.
Yeah, and just start the slideshow.
So.
Yeah, we got you. Please carry on.
Yeah, so like I mentioned that they were first discovered in 1930s, then in chicks, then in 1960s in humans, in US and in United Kingdom, but they have been present in animals, and they have a capability of transmitting between animals and humans, and it is called spillover event when they transmit from animals to humans. Coronavirus family, this includes viruses which cause common cold, then the famous SARS, severe acute respiratory syndrome. This was first identified in 2003, but there have been further episodes over the years, 3 or 4 quite well-known episodes. The other one was Middle East respiratory syndrome, which was in 2012. This affected about 8,000 people and caused nearly 700 deaths. And now the recent one is COVID-19, which is because it was in 2019, and a very serious illness, which has now become a pandemic. The outbreak started, it is like recognized to be started in city of Wuhan. And initially it was thought to have been linked with animal to human transmission in a human people who visited wet market. But now human to human transmission is ongoing. Health workers are being infected as well. To control the disease, the main principles are biosecurity, which means that this is a method of controlling spread between herds. Herds means population and groups of people. Then biocontainment, which is within the herd transmission. Resilience and immunity, which is vaccination or natural immunity. Surveillance and testing to track the disease and check for presence. Biosecurity is a difficult and expensive process. It has lifestyle impact. It works very well if timed at the right time. Biocontainment, it slows the response, the spread of the disease. All countries, because it's a pandemic, so the recommendations by WHO is early detection helps, isolation of cases, case management, contact tracing, prevention of onward spread of COVID-19 infection, and WHO is recommending to share all data because this is a rapidly progressing and evolving situation, and every day the guidelines are changing according to how the situation is evolving. We have no vaccination and there is no immunity. The herd, the population, everybody is totally susceptible. Test is there and we are testing suspect cases, and now there are actually tests available for more, like there has been a study where they tested NHS patient, staff and other people who could be the cases. This is what we can do at this moment in time. There has been a study that 38% of NHS staff who was asymptomatic actually have got antibodies for COVID-19. So there are asymptomatic carriers which can actually spread the infection. Symptoms are generally dry cough, which is persistent, like severe bout of coughing or recurrent coughing, runny nose, sore throat, fever, diarrhea. These are the cases which are usually managed at home, but then in severe cases, we see breathing problems, chest infections, people needing ITU admissions, and Dr. Ali Raza is going to talk about how many cases recover and mortality figures. So I'm not going into that now. In children, it is also presenting with similar symptoms, but fortunately, children have proven to be quite immune to this problem. Though they have been tested positive, they have required ITU admissions. Some of them have unfortunately, sadly, lost lives, but they have predisposing conditions. Some cases, some new reported cases present with multi-system inflammatory state. These children are presenting with gastrointestinal symptoms, diarrhea, vomiting, also inflammation of the heart. And pediatricians are quite familiar with it, a condition called Kawasaki's disease, and also toxic shock syndrome. Some have presented that way. But at this moment in time, again, there are very few children who have presented. A lot of them have made miraculous recovery, which is really reassuring. How to protect ourselves? There have been constant emphasis on hand hygiene. Wash hands with soap and water. Respiratory hygiene is another very important element, which is like coughing and sneezing, using elbow. The other important thing, which is if there is contact with animals, it's very important to ensure that hands are washed thoroughly after any contact with animals. Or cooking meat in Western societies, a lot of the times meat is cooked in a certain way, certain preferences, which is quite raw. That is actually, it is recommended to cook it thoroughly. I'm sure most of you have seen this slide one way or the other. It is a constant reminder by the government to keep distance, wash hands, avoid shaking hands, sneezing, I mentioned respiratory hygiene, and stay at home with cough and fever, but otherwise as well. These are a few slides which are, this is a study which was done by Andrew Dean and James McDonald. They have put some slides together, and this is the data from WHO and other surveillance groups. And it's self-explanatory. I'm not going to go into the details, but you can see total cases are now 3.75 million and deaths 265,000 so far, and it's constantly increasing. This is United Kingdom data, which is showing daily figures and also the total number of deaths over the last from 15th March till 6th of May, and we have now gone over 30,000 figure. The trend is, it seems that we have reached the peak and it's coming down, but then there are variable figures on day-to-day basis. It seems that lockdown is perhaps working and other measures, and we are not sure what will happen if the lockdown is released or if there is any other things which can help. These are interesting figures about differences between men and women. Over 85, the mortality is equal, men and women. In younger people, in people under 15 and 21, it again kind of matches. But in the middle age groups, there is a huge difference between men and women. And there is one hypothesis is that men have more ACE receptors, where the virus replicates. So that could be the reason. But like I mentioned earlier, it's a rapidly evolving situation and more evidence is coming. And it's still early days to really reach a conclusive outcome. Is there a treatment? No specific treatment yet, but symptoms are treated. Some are just treated at home, others need ITU and hospital admissions, one way or the other. And WHO is constantly on the case and sharing information with everybody. Um, thank you very much. I'll pass it on to now Sundus, so she can continue with the rest of the presentation.
Thank you, Dr. Shaheena. I'm not sure if anyone has got any questions. Do we take the questions now, Dr. Chughtai?
Yeah, no, I think at this point, if Dr. Sundus Yahya can continue from where Dr. Shaheena left, I'll appreciate that.
Okay, thank you. I'm just sharing.
Yep. Yeah, we can see that.
You can see that? Okay. So what I'm going to say today is actually a snapshot. It's very difficult to try and encompass literally every single complication and the guidelines. But what I'm going to try to do is particularly signpost to you guys how to manage.
Dr. Sundus, can I ask you to share again? I think there is some issue, connectivity issue. We don't see your slide. If you stop and start again, it might work.
Let's see. Can you see now?
It is trying to. It's saying that you're beginning to share, but the slides have not come up yet. Maybe can you share the actual desktop, because it is sharing empty screen. So maybe you can share the desktop screen where the slides are.
Sorry,
I should say desktop screen.
Sorry, I'm just going to stop the slideshow and then
that's fine.
start again.
No, we have time.
Sorry about that.
Totally understand. This is the live precautions we always have to be taking care.
Yeah.
But,
no, it's fine. It's just sometimes the connectivity, when you share desktop, it takes a lot more memory, and sometimes it can do that. So it's fine. And if you start share button again.
I think some things happened to my slides. Just 1 second, sorry.
No worries, no worries. As Dr. Shaheena Anjum, we can do that. Do you want more time? We can get Dr. Ali Raza.
I can I'm just gonna quickly pull it out from my email. Yeah. Just 1 second.
Dr. Shaheena Anjum has given us a good review and a good kind of a preview and understanding of COVID-19's current status. And I think if we'll also move to Dr. Ali Raza at this point, if you want more time, Dr. Sundus.
Yeah, do you want to move to Dr. Raza? And I'm just going to quickly fix this.
That's fine, no worries.
Sorry about this.
No, not at all, not at all. Dr. Ali Raza?
Yes, sure.
You want to share your work and topic information on COVID-19's atypical presentations. Do you want to start now?
Yes, I can start now.
Yeah, please proceed.
Okay, as Dr. Shaheena has said, that this is a virus which is not that new, but the strain what we seeing these days that's why called novel, because it is something new for us, and still understanding is being developed about COVID-19. One thing very much important, as we already know, the natural history of COVID-19, that 80% have mild to moderate disease, while 15% require admission to hospital for severe disease, and 5% require admission to an intensive care unit and are critically ill. So end-of-life care, which is our topic of discussion today, comprises of these 15% which require admission to hospital and 5% which require ICU care. So there are some difficulties in counseling these patients. because the person is likely to have become ill and deteriorates quickly. So the opportunity for discussion may be limited or just lost. Families and carers may be shocked by the suddenness of these developments and may themselves be ill or require self-isolate. So we have to think about the other mediums, how we can counsel effectively, like through video calls between family and the doctor, and the video calls between the patient and the family, and the audio calls. So an ideal scenario can be that family should be involved at every step, even despite that they are not on the bedside of the patient, so that effective communication can be done. Then comes the ethical dilemma. In a public health emergency, values other than autonomy may predominate. Uh, uh, we know that for every patient, autonomy is the right of the patient. However, and a mutual decision should be made. But in certain circumstances, when the health system becomes overwhelmed, the principle of justice need to be implemented to try as the patient.
So we're just trying to connect back to Dr. Syed Ali Raza. There is some interruption due to internet.
The age, especially an age of greater than 70 years, then comorbidities, poor functional status of the patient, severity of the disease, like if the patient has developed ARDS and his scans are really bad. But we should always prefer patient wishes and expectations. So what we should offer, apart from standard ICU care, a flexible terminal care plan should be discussed depending upon patient's condition, including an option to don't resuscitate, an option not to intubate, non-escalation of treatment, and withdrawal of support. Do remember that these are the things we are talking that when the system is overwhelmed, and then we have to offer these flexible things to the patients. Then what should be the principle of care in terminally ill patients? The principle should be correct or correctable. For example, as Dr. Shaheena has already told, that there is no any specific treatment for COVID-19. So the treatment is basically still based on supportive care. But we should remember that we should also correct whatever is correctable, like antibiotic treatment for a secondary bacterial infection may improve fever, cough, breathlessness, and delirium. Optimizing treatment of comorbidities such as COPD or heart failure may improve cough and breathlessness. And then comes the symptomatic management. And this is based on the common drugs available in every country, which we are already using in our ICUs and medicine wards. So that includes for fever, we should choose paracetamol. Remember, NSAIDs to be avoided if patient has chances of recovery from COVID-19. However, it can be given to terminal patients with poor prognosis. Then same for breathlessness, we know oxygen therapy, including high flow nasal oxygen cannulation, non-invasive ventilation and invasive ventilation. And again, along with that, codeine containing syrups and Oromorph if available. And for delirium, first of all, we should always see the cause of the delirium. Usually there is a urinary retention, constipation, infection, other than the COVID-19. So we should ease out these causes, we should treat them. And then for irritability, we can give haloperidol, midazolam, lorazepam. All these are also available in almost every country. And for secretions, we can give hyoscine, glycopyrrolate. This is the list of the drug that is actually more simple regimen, which any ICU care can use. So the most important message there is that we should offer end-of-life care to patients who are, especially the 15% of the patient who develop dyspnea as they come to the emergency. We should start counseling them about the poor prognosis related to COVID-19, especially if they are old. And we should that go they want to be educated or they don't be educated. And then we should all their care will not be compromised, and a good treatment as care would be given to them to keep comfortable and give them a dignified death if it is in.
Dr. Raza, there is slight interruption from your side due to perhaps internet connectivity, but please carry on. If you're able to hear us, sometimes because of the traffic on the internet at this time in that particular domain or geographical area, we have overloading of the capacity and we are experiencing some slight interruption to the webinar. But at the same time, Dr. Ali Raza, thank you very much. Are you on the last slide or have you, are there more slides to go?
I'm finished.
Yeah, thank you very much. It was very informative, especially the therapy, and you mentioned secretions, hyoscine, because this is an area which is commonly ignored, that people do not look after the secretion side of the patient's hypersecretory mode, and that becomes very difficult for the patient to breathe and manage. But thank you very much for sharing all this. We want to go to Dr. Sundus Yahya regarding her presentation, and then we'll take this.
Yes, I should be able to share with yourselves now.
You got it. Yeah.
Yeah. Okay. I'm just going to try and share now.
Did screen.
Sorry, I'm just sharing the screen now.
The slides did come on the screen as you were clicking, and they're yeah, it is trying to share the screen, and it is yeah, we got your slides, and then you can start.
Okay, thank you.
And slideshow.
Am I on the slideshow?
Yeah, and you can start the slideshow mode. Yeah, we got you there. Okay.
I'm sorry. Sorry. Okay.
No, it's fine.
Yeah. So I'm sorry for the technology glitch, but I literally had a heart attack there because I think I lost all my slides. Right. So I'm just gonna just advise all the attendees. I think the best resource at the moment will be your trust guidelines or your hospital guidelines. You know, they are all being fed into from the WHO and the international guidelines. I'm just sharing what we personally follow. These are University Hospital Birmingham guidelines, and essentially, you know, all of us should have this like a snapshot or a flow diagram, you know, where it is not just helpful for you know, the junior staff, but also for the senior staff as well, and particularly for ourselves, because a lot of us, you know, as you may know, have been redeployed to the acute medical side of hospital settings now. So you know, there are signs and symptoms and the investigations and imaging, and then you know, you just flow through all of that. So it is a bit blurred, but I think the gist of the slide was just to show that you know, there are resources available. And then what I wanted to highlight particularly you know, between that was that whenever we have any viral infections, you know, the bacterial secondary bacterial infection almost always happens at the same time. So what we always have to be very wary of is the use of antibiotics. I was actually just sharing with my colleagues over in Pakistan. I think somebody has just proposed a cocktail of azithromycin and hydroxychloroquine, and I think the worst of it is that, you know, without any evidence base, using antibiotics is going to cause a lot more resistance. So just be very, very careful when you are actually initiating antibiotics. Again, this is what we are using currently within our trust. Each hospital and each country will have their own, you know, microbiology guidelines, and it depends on, you know, the resistance that is prevalent in that or endemic within that area. So you have to follow that. One of the other very important aspects that we have learned with this COVID-19 is the microangiopathy that is developed. That is seems to, and probably Dr. Taimur Mirza would elaborate on it maybe a little bit more later on as well, that, you know, particularly the lung injury that we are seeing is a lot more related to the microangiopathy. So there is a very big drive at the moment to anticoagulate these patients. And again, this is a snippet of how we do it locally. You can use other drugs, including rivaroxaban or oral anticoagulants as well. But remember, you have to work along with your hematology colleagues because they're not licensed medications. But we use enoxaparin, or you can also use low molecular weight heparin, which I know is most commonly used in countries like Pakistan and Saudi Arabia and Middle East. Proning is something that again we are learning as we're going along. There's a lot more that is being done in the ITU setting, but I just wanted to briefly talk about proning in the non-ITU setting. This is particularly pertinent again in patients that are not suitable for ITU, who have got more comorbidity, or even patients that you would want to manage at home. A lot of patients these days have got saturation probes, but you do need some guidelines. So I'm just going to signpost you again to the Intensive Care Society. Again, this is a flow chart. I know it's not very clear, but I'm just going to highlight this. So this is the time to position changes for the patients undergoing conscious proning process. So this is non-ITU proning guidelines. But essentially, I think, again, what I'm just going to warn you is that it has to be done by the doctors and under supervision. You have to monitor the oxygen saturations for 15 minutes after each position to ensure that the oxygen saturation has not decreased. And again, if you are getting concerned, then you must just stop and probably get help from your anesthetist colleagues. Now, the anecdote or the pathophysiology behind this is that what you're trying to do is to recruit the posterior segment of the lung. You're trying to prevent the atelectasis, which happens a lot when the patients are obviously, lying on their backs with this condition. And you are trying to improve the VQ, the ventilation perfusion ratios in these patients, but also to try to get rid of the secretions that these patients develop over time. So, it's a half an hour stint, and essentially what you do is try within half an hour, but if the patient can manage, you try to get them to lie fully prone for up to a couple of hours. Then you ask them to turn on their right side. But remember, when they're sitting, essentially we don't try and get them to sit upright, again, because we breathe more from the lower part of the lung, and here we're trying them to recruit the posterior segments. So we try and get them inclined at 30 or 60 degrees. You can either do it, particularly for the patients at home. They can put lots of pillows underneath their headrest, or sometimes, and think that is something that you just going to have to be innovative. You can even, I've seen patients putting bricks underneath their posts of the beds. And if they are managing okay, then you just continue to repeat the cycle, and that has actually been shown to be very good, and prevents hospital admissions and prevents patients requiring the non-invasive ventilation as well. And I've given the links here as well, which I'm quite happy to share on the FGK website as well later on. The other thing that I just wanted to talk about was end-of-life care. Unfortunately, we've always been very bad in looking after our patients who are towards the end-of-life care, be it because of diabetes or stroke or cancer care or heart condition, but we are particularly have to try and get better in that. The comfort drugs, and again, I'm just going to give you examples. You may or may not find these medications within your country, but there's always an alternative available, so try and do that. These patients, remember, the fear of breathlessness and not being able to breathe is huge. These patients get very agitated, they're very anxious, this fear of dying. So you can liberally use midazolam and lorazepam in these cases. Although we use strong opioids typically for pain, but being a lung cancer specialist, we use a lot of it to relieve breathlessness. And essentially, it does that by reducing the sensitivity and the reflex response to the raised CO2 levels that we see in the respiratory failure. So If you haven't got morphine available, you can by all means use oxycodone. And again, don't be shy to use a large dose of morphine, because a lot of them will actually require up to 10 milligrams of morphine every couple of hours. The other thing that I just wanted to highlight here is that particularly in the third world countries and in the Asian communities as well, there's a lot of stigma about using these medications. You just have to get the family by your side and reassure them that whatever drugs that you're using are not going to hasten the death process. It's not going to accelerate it. It's only going to make the patient comfortable. So that is very important. If the patient continues to remain very agitated, you can use levomethomazine and haloperidol. Haloperidol particularly we would use as first line for the agitation and delirium. And then you can add on levomethomazine on top of it. Hyoscine, I mean, a lot of us, again, are very, very bad in diagnosing the death rattle. It is extremely uncomfortable for the patient, but more distressing for the family as well. And it is quite upsetting for the staff. So please try and identify it earlier on, commence the patient on hyoscine butyl bromide. The other thing that I want to point out here is that it's not going to get rid of the secretions that have already been there. So you still have to do their suction and try and loosening their airways and get some physiotherapy for these patients. But it's going to reduce the production of the secretions. So again, I'm not going to read all of that, but essentially it was to give you the gist of, you know, the kind of doses that you might start with and you can escalate to. So, you know, for midazolam, you can start off with 2.5 milligrams subcutaneous or IV. But also remember that if the patient is frail, don't give them too much. Begin with a lower dose, and then you can titrate up to 10 milligrams instead. You can also go subcutaneous doses if you've lost the IV line. You know, that's not really an issue. But also, I think the important thing is that whatever you initiate, you have to go back and reassess to make sure that whatever you have started is actually working. Stronger opioids, again, you know, you start off with morphine and add in benzodiazepines if the symptoms are not resolving. But the other thing to bear in mind is that if you've got a patient started on morphine and he's requiring more and more morphine, for example, if you've gone up to a couple of hours of giving them morphine, then it's best to start them on a syringe driver. So syringe driver is essentially a syringe that constantly pumps the drug over 24 hours, and basically you titrate the doses. Again, if you're unsure, you know, I'm quite happy to share with the links, but also that, you know, all of this is available on the WHO and all the big relevant websites, and particularly the Royal College of Palliative Care Medicine has issued these guidelines. So if you have already put the patients on morphine and they're still not responding, I think you have to just step back and question yourself. Are you giving too less? Or are you giving too infrequent? Also, if you've not been using morphine alongside midazolam, you know, seek advice. There's a lot of information out there, and by tweaking the doses, you can get the balance right. Antipsychotic drugs, we try and avoid it, but what we have noticed is, I'm just going to touch on it in later a little bit more in a slide, is delirium. And with the delirium, feel free to start with levomethomazine, and you can actually use that in conjunction with morphine and midazolam. Levomethomazine is a very good drug, but again, if it's not readily available in your country, you can use oxycodone instead. So I've already talked about this. If you haven't got hyoscine butyl bromide, the alternative is glycopyrronium subcut, and again, it's a very, very good drug. You can use it quite early on if the patient has started to build up secretions, and just to try and prevent that. Now, I just wanted to talk about delirium, because delirium is something, and particularly when you are, managing patients out in the community, that you may actually come across. Again, as medics, we are quite bad at identifying this in the acute medical setting anyways. But there's a very simple tool for it, and it's called a 4A test. It's a screening tool that is designed for routine use, and anyone can use it. Essentially, it is based on arousal, attention, abbreviated mental test, and acute change. If you don't even know that, you just need to ask yourself a single question: has this patient been more confused than usual? Okay. And if that is the case, please don't hesitate to start them on first-line haloperidol. But if there is any contraindication to haloperidol, you can also always use quetiapine or risperidone. The second line, if they're not responding to that, is either lorazepam or clonidine. But for terminal delirium and agitation, by all means, you can use syringe driver of midazolam, levomeprazole, and haloperidol. Now, you can very safely give all these three drugs at the same time, and again, just keep reassuring the family that you're not actually accelerating the process of death or dying. It is just to make the patient comfortable. The reason why these patients are getting delirium is, again, as Dr. Shaheena earlier mentioned, is the ACE receptors, the angiotensin converting enzyme receptors. They are in a high proportion in the brain, in the lungs, in the gut, which is where the virus goes and attaches and replicates, and therefore you get all these symptoms. The incidence of delirium is actually very high within this population. It's about 40% of patients will actually have delirium. So, I mean, that was my slides. Again, the idea here is just to make you guys aware of the complications that we are actually seeing in the hospital setting, to make you guys comfortable using all these medications, but also that it's not that you can't do anything for these patients. We can still do a lot for these patients. It is still symptomatic management, as Dr. Shaheena earlier alluded to. But a lot of these times, these patients can be helped, and all the distress and anxiety that the family goes through and the patient goes through, as well as the staff, the moral injury that we are sustaining, that can be prevented. Yeah, so I think I'm just going to stop there. I'm sorry, I can't hear.
Thank you very much. I think Sohail is just coming back. What I would suggest is, obviously, because we are running a bit short of time, there are lots of questions. If we can, go through some of those questions very quickly and the panelists answer, that'll be great. The only other point I would like to mention is, I think all the content, the resources which Dr. Sundus Yahya have shared, we will put this on APPS UK website. So obviously you can actually download those and use in your own hospitals. Sohail bhai.
Thank you. I'm just going to quickly answer a very pertinent question, if that's okay. I think I'm just reading. Yusuf Hafidi has asked, how do we manage gastrointestinal disorders, nausea, vomiting, diarrhea, and also what specific issues we must have to manage inflammatory bowel syndrome? So just going to briefly touch on that. So we are actually seeing about 40% of the patients with abdominal symptoms only, actually. They wouldn't have any cough, any fevers. So, you always have to keep an open mind. You would do the basic stuff again, you would send the stool culture, for microscopy and sensitivity. And by all means, you can use the medications that I have actually just alluded to. When you are using other drugs such as ondansetron, you just have to be careful that it will actually cause constipation, and you don't really want that in somebody who's actually got inflamed bowels. The use of dexamethasone or the steroids to try and suppress that, again, has to be done with specialist input, because steroids are, again, we try and avoid that, particularly in the COVID-19 patients. But your advice to the patients who are already on inflammatory drugs is just manage their symptoms as best. There is no current guideline or no advice that is asking patients to taper their immunosuppression. We want them to just carry on with their medication as normal.
Okay, thank you very much.
Can you hear me, Abdul? Can you hear me?
Yes, we
Yeah,
can
we
hear
can
you.
hear you.
Okay, there was a temporary blockout. I don't know, there's an internet issue. But thank you very much, Sundus, for giving a very elaborate presentation. Dr. Taimur, Dr. Sundus mentioned positional proning with timed management. What are your take on that? Timed management of proning?
Sohail, it is usually when the patients are not admitted to intensive care unit. I think Sundus has shed the light on that, on the proning. This is when the patients on either on CPAP or on high levels of oxygen, and they are being desaturated and become hypoxic. That's the reason when we ask them to go prone. And that's the particular time period when we ask them to prone. That is called self-proning. So to avoid or to delay the intubation scenario so that they can be admitted to intensive care unit. So it is, as she has rightly mentioned, about 2 hours to 3 hours we give them to lay on their tummy so that they have got more lung surface area for better oxygenation. So it is between 2 to 3 area to prolong the time, to get more time for intubating them, or they may sometimes get better because of the self-proning.
So it's very valuable, as you also reiterated. Dr. Shahid Sharif, both previous presenters mentioned, in fact, all of three of them mentioned about the use of narcotics for the end of care situation. What is your take on a selection of narcotic medications at that point?
I agree with them, both with Dr. Syed Raza and also Dr. Sundus, that we start with smaller doses, so like morphine or morph, and then we can titrate the dose according to patient's needs and response. So it's very important to keep the patient comfortable, not only comfortable, but also it helps in the breathlessness, reduces the anxiety, and so it's very important.
So there are questions, there is a flowing list of questions. Can I take one of them? And I think it's Zainab Akbar. She's asking that if the presenting symptoms are GI related, what is the clue towards sending the patients for COVID screening? Dr. Shaheena, can you answer this question? If there is a GI related symptom, what is the pretext for sending the patient for COVID screening? Dr. Shaheena Anjum.
Well, generally, any patient who presents with, we need to categorize patients the way their symptoms are. So if they have diarrhea and vomiting, history is the most important thing. Proper history, see how the patient is. COVID patients usually have temperature as well, without any respiratory symptoms. I can't say anything more than the proper history, assessment, see how the patient is, and treat it like any other patient that you will refer to the doctors for further assessment. If there is any possibility of COVID-related symptoms of dry cough, temperature, any contact, then obviously that can be suspected. But generally treat them like any other patient, like Sundus already mentioned in the previous comments, that any person who has whatever, we continue manage them according to our own guidelines, the way we do them. If we start, sorry.
Thank you. I think we've got lots of questions. So, Hilbhai, can I ask 2 or 3 questions very quickly?
Yeah, go on, please.
I think these are related to Dr. Taimur Mirza. First question on the Facebook is, do we need to do anticoagulation on all patients?
Yes, I have answered this question in writing also, but I will mention here that yes, in UK, we normally have a protocol to give all the patients low molecular weight heparins. But since this condition is more related to the micro and macro thromboembolism, because on the most of the patients on autopsies, it has been found out that they have got pulmonary embolism in the microvasculature, which hinders the uptake of oxygen, and hence the patients are hypoxic. So in those conditions, we do the D-dimers, and the D-dimers are high. We put them on the treatment dose of low molecular weight heparins.
Okay, thank you. Another question, which is coming from the Facebook as well. A patient becomes positive for COVID-19 3 times, and the patient is actually symptom-free. Do we need to keep them in the, in the hospital?
Quarantine.
Yes.
We need to keep them in quarantine, keep them in self-isolation wherever possible.
So obviously we will continue till the test is negative. Is that what you're
Yes.
saying? Okay. Another question, very quickly.
Yeah, there are a few more questions coming in, and I think one of the questions is about, again, pregnancy situation of COVID with pregnancy. But I think the last webinar does take you through a lot of questions and answers. So I will skip the questions on pregnancy on this one.
Yes, I think, but this is related to Taimur by last question, which we have. This is a patient who is 60 to 70-year-old, suspected of COVID, with saturation of 70% on high flow oxygen, intubated, mechanical. Saturations are running now around 80%. What is the criteria of end of life? I mean, when do we say enough is enough?
And normally in England, we are not putting them on end of life until or unless they go into multi-organ failure. They are on maximum strength of noradrenaline and their organs are failing. That's the time when otherwise we keep them, we don't take into consideration. I have seen patient reversing from PO2 of as low as 6 for a couple of days, but we did not put them on end of life pathway. We kept on treating them. If they go into multiple organ failure, okay, and you go on to quadruple strength of noradrenaline, then that's the time to call it a day. But otherwise, we keep them treating, and the patient, they do turn the corner and they start getting better.
We have a question from Arzinda Fatima. Very interesting question that we're getting, it's from Pakistan. We're getting a lot of false negative COVID PCR results in Pakistan. False negative in Pakistan. What is the best diagnostic test for COVID? It's a very burning question. Sundus, do you want to answer this question?
Yeah, I think what I'm going to say is it's not just Pakistan, actually. The false negative rate is about 30% even in the swab test that we are doing. And we have already realized that it is actually very heavily dependent on the operator as well. So a negative test in the absence of some symptom is fine, but a negative test in the presence of symptoms should be taken with caution. And it's not up until sometimes that you actually have to repeat the test 3 times to get a positive sample. So if you've got a high index of clinical suspicion, you would still treat them as a potential COVID patient and just not rely heavily on the test, altogether.
Yeah, I've got another question. We got Dr. Hafeezur Rahman. Dr. Hafeezur Rahman, welcome to the group. Can you hear us, Dr. Hafeezur Rahman? Dr. Hafeezur Rahman, he's a consultant anesthetist. Dr. Hafeezur Rahman, can you hear us? If not, then I'm going to give this question to Dr. Taimur Mirza. Why is morphine and midazolam used in these patients with dyspnea? Why not remifentanil? Dr. Taimur Mirza, this question is from Prince John.
We do use, it depends on what is the setting. Is the patient on an intensive care unit or is the patient on general wards? Then it depends, why are we using it? Are we using it for end of life care? Then yes, we will use the morphine and midazolam. But if on the intensive care unit, we can still use them. Most of the ITUs, although use propofol and alfentanil, but we can still use on remifentanil, but remifentanil is only used in a controlled environment where the patient is on ventilator because it has got a great side effect on respiratory center. It suppresses the respiratory center and patient stops breathing.
Is there any contraindication of remifentanil? Any absolute contraindication?
No, there is no contraindication except that the environment should be controlled where the ventilation is available.
We got Yusuf Hafidi asking a question, the GI symptoms, nausea, vomiting, diarrhea. So how do we manage this, especially in a Crohn's patient of COVID-19? Dr. Syed Ali Raza, let me take Dr. Syed Ali Raza. I think, can you unmute your mic?
Sorry, Dr. Suhail, we actually answered this earlier.
It's about COVID-19 in Crohn's patient.
Yeah, we did. I think when we lost you, we actually, but Dr. Raza can certainly take on the other one. Why only GI symptom? If the patient only has GI symptoms, then what will be the investigation of choice?
Yeah, how would you manage GI symptoms in your setting, Dr. Ali Raza?
I think even in this COVID era, we should not change much practices, keeping in mind COVID-19. Definitely, it can be our screening test based on the data that are many patients presenting with the GI symptoms. But rest of the panel, including GI panel, and it should be same. This is my take on this.
So I think the discussion can keep going, but we have a lot of knowledge put through. Let's try and retain as much as we can today. We had very able panelists who have gone through their presentations. Dr. Irfan Rashid, you manage patients at a primary care level. What is your take on all this discussion at a primary care level today?
In the primary care level, what we're seeing in our practice, the people, there's a lot of mental health issues going on regarding anxiety. They're suffering with lots of stress. They are reading lots of stuff which isn't true, okay, and hoping for different medications. And sometimes, I personally see that there is some type of denial as well, and not following the strict guidelines, especially the social distancing. And but now, after seeing all these, people have realized the consequences of not following the guidelines. What I see personally is a hell of mental health issues in community.
So this is a significant area we must not ignore. In fact, one day we will do a webinar on this topic. I would invite Dr. Shakeel Puri, the president, to have a concluding note before we say bye for this webinar. Dr. Shakeel Puri, the president of APPS UK.
Thank you very much. It's been an eye-opener, and I think they're having very practical and very useful, experienced notes and very useful points raised here. I hope the people who have been watching all around the world have learned something. I certainly have enjoyed it very thoroughly. I mean, doing these things on a live basis, there are always some hiccups, but I'm very, very thankful for Dr. Suhail Chughtai and Dr. Abdul Hafeez and my brother and friend, Dr. Irfan Rashid, for conducting this so well. I'm very thankful in person for Dr. Syed Ali Raza to join us from UAE. I know the time difference and the difficulties with the internet and so forth. Our chair, respected Chair Shaheena Baji, and Dr. Shahid Sharif and Dr. Sundus Yahya. Very thankful. And I'm also hoping that this will carry on, and inshallah we will carry on teaching and spreading the knowledge all across the world.
We will, inshallah. And I want to conclude with Dr. Abdul Hafeez telling us about the next Sunday's program. Dr. Abdul Hafeez.
Just 2-3 quick announcements. Number one, obviously, as we said before, we will be giving out the CPD certificates, but you have to be APS UK member. So please join APS UK if you would like to claim this as a CPD point. Number two, the presentations, all the content which we have will be on our website. Give it a little bit time, obviously, to maybe a day or two to upload this. The webinar has been recorded, and we will also share the link on APS UK website if you would like to share it with other colleagues who might benefit from this. Next week webinar, we have the Governor of Punjab from Pakistan, who is actually joining us, and we are going to discuss telemedicine and how we actually treat, manage COVID patients via telemedicine as a telehealth advice, and how we make the assessment.
Thank you very much, everybody. And I think I must take time out to say thank you to the audience who made this possible and who actually inspired us to do this and keep doing it. And we will keep doing it. We promise that APPS UK will not diverge from its ethos of advancing health and changing lives. We will be back with more information, more knowledge, and please give us your feedback on how you want it to be even better. We would respect your feedback and we will implement changes accordingly. Thank you very much, and I really appreciate all of you guys. Have been wonderful, all my presenters and all the audience. Thank you, and we'll see you soon next week.
Thank you very much.
Thank you very much. Bye-bye.
Thank you.
Bye.
Bye.
Bye.